Next, we'll go over the inline suction procedure. If you're doing inline suction, not necessarily all the time, but I'd say 99.9% of the time, if you're doing inline suction with a patient, they're going to be intubated, mechanically ventilated of some sort. There are some scenarios in which you might do it with someone that's not mechanically ventilated, but we'll discuss those at a later time. You want to hyperoxygenate your patient. On most ventilators today, there's going to be some type of suction button, increase O2 button, O2 breath, or what have you. On the servo I ventilator, it's been broken off, but there's a clear plastic pane that can be raised up and dropped back down over, but it's been broken off of this one. But you'd lift that up, and underneath here, there's an O2 breaths button right here. So you'd depress that and hold it, and once your O2 breaths are active, you're going to get 100% oxygenation in your alarm. You want to silence your alarms. When you do that, that's silence for 2 minutes. You want to make sure that you hyperoxygenate your patient. So while I demonstrate with this other closed system suction catheter how to go through the procedure, I'm going to allow this patient to be hyperoxygenated while we do that. So with this, you've got a lavage port. So if you wanted a saline bullet or a saline syringe, either one, you could put a lavage through here. If you are going to lavage, this port does turn. So what I would do, I would support your system, and I always like to attach my syringe with the saline in it or the saline bullet here. And if I'm going to lavage, I'm going to advance the catheter slowly, just a little bit, so this gives my saline lavage something to ride down into the endotracheal tube. So once you've squirted your saline down for the lavage, now keep in mind, I'm not endorsing saline lavage because studies have shown that it should not be routinely done. I'm just saying I know that it's still done out there, so I'm telling you, if you choose to do a saline lavage, how to go through and do that. So allow that to ride down. And basically the insertion of this catheter, if you'll pinch the catheter, press, relax your grip, and allow that sleeve to travel back with you, then you can run that catheter down the tracheal tube until you meet resistance. That resistance point should be the carina. Then you'll pull back about a half centimeter, then apply your suction and withdraw the catheter all the way out. You've got 15 seconds to get that done and over with. When you withdraw this catheter, you want to make sure that you don't pull this catheter too far back, because if you get to where you can see that black line in here, you might be too far backwards, and this sleeve is going to fill up with some of the breath that's supposed to make it to the patient. Conversely, if you don't pull it back far enough, then you've got catheter that's left in the Y, so that could increase your airway resistance and cause your peak pressure alarm to go off on the ventilator. This ventilator is going to alarm again here in just a second because I've exceeded the 2 minutes in which the alarm has been silenced. So we'll go for two more minutes. Another thing as far as technique is concerned, before you suction, make sure that this port is in the unlocked position. That way you can depress it. If it's locked, you cannot depress that port. Some people have a tendency to leave it like that, which it does indeed lock it, but in the off chance that this patient happened to be in a continual lateral rotation bed or what have you, and they got moved, that could click into the unlocked position, and then if the patient rolled over on that, then you've got a vacuum going through the ventilator system, so you're going to be constantly pulling some of the air out that patient's supposed to be breathing. And if you've got someone that's having issues oxygenating or what have you, and you're trying to develop a significant amount of mean airway pressure PEEP throughout the system by allowing that to be depressed, constantly depressed because the patient inadvertently rolled over on it because we didn't do what we were supposed to do to lock it. It's not very hard. Like I said, some people turn and leave it like that. I'm an advocate for going ahead and turning it all the way so that it doesn't press down and there's no chance, because actually that's got to be lifted up a little bit in order, so the chances are a whole lot less likely of inadvertently being unlocked with it like this than it would be that way. And always make sure that it is in the unlocked position before you advance your catheter, because you don't want to get your catheter down inside your patient and then have to use part of your 15 seconds worth of suction to to lock or unlock that catheter. So make sure it's in the unlocked position. We'll go ahead. We also want to make sure that we understand, and when you're done, make sure that you close your lavage port as well. So pinch, slide, pinch, slide, pinch, slide until you meet your resistance. Pull back a little bit, apply your suction, and then come straight out. All right. You know, and you'll see some people that get pretty rough with it. Just take it easy on the patient, what have you. And then after you're done with your suction pass, make sure that you lock the catheter back and make sure that you've not pulled the catheter too far back and you're not leaving catheter at the Y. One other thing I'm going to mention with overall suction technique is when you're suctioning a patient, I have a tendency to see a lot of individuals in the hospital do this. They'll come out and suction, but yet they pull the catheter like this. Well, that kinks the catheter, so that really decreases the overall amount of suction you're going to see. So I really would be a proponent of going down with your suction catheter, applying your suction, and coming straight out with that. And then always, doesn't matter if your patients are comatose, heavily sedated, or what have you, always tell them what you're getting ready to do. Always treat the patient, no matter what, that they're there, alert, oriented, what it is that you're doing. Always tell the patient what's going on. So that being said, let's go ahead and do the inline suction procedure right quickly. So if I'm coming in to do an assessment on this patient, I would have hit the O2 breaths button ahead of time to do my pre-hyperoxygenation. I'm going to do an assessment. I'm going to listen to the breath sounds to make sure that they may have rhonchi or what have you. That's something that would indicate a need for endotracheal tube suctioning. Another thing that I'm going to, so while they're being hyperoxygenated, again, I'm not going to put saline down because this is a mannequin. That'll be practitioner preference later on down, but do know that studies have shown that the habitual use or routine use of saline lavage is not necessarily warranted and in many cases can do more harm than it does good. All right, so my patient's been hyperoxygenated. My assessment tells me that the patient does indeed need to be suctioned. So again, I want to make sure that I'm not going to exceed a dangerous vacuum pressure. So I'm going to occlude this in and see that I am at negative 80 millimeters of mercury. I know that the camera may not pick that up very well, so please take my word for it that is negative 80 and don't have an excessive vacuum pressure that's going to set up. I'm going to make sure that this is in the unlocked position so that when I go in and make my suction pass, I don't have to worry with that. I'm going to take this hand and support the endotracheal tube and the Y of the ventilator circuit. So I'll take and I'll advance my suction catheter until I meet resistance. That resistance point should be the carina. I'll pull back a half a centimeter or a centimeter, and now I'm going to go ahead and withdraw my suction catheter until I've got this back. And this particular suction catheter has a one-way flap on it that allows you to know that you're got the catheter withdrawn enough. So if I didn't get a lot of secretions, I may or may not make another suction pass. If I'm going to make another suction pass, what I'm going to do is I'm going to hit the O2 breaths button again to make sure that the patient continues to receive 100% oxygen while they're resting. I can listen again to see if another pass is warranted. If I deem another pass is warranted, again, check to make sure that that's in the unlocked position. Support your endotracheal tube and wire the ventilator circuit. Advance your suction catheter until you meet resistance. Tell the patient, it's going to cause you to cough, 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 and then pull that out. Remember to always talk to your patient and let them know what's going on. Once you've done that, if you utilize the saline lavage, I would advise you to take that saline, put it in, squirt a little bit in here while applying suction, and that's going to clear your catheter. And that's going to clear your catheter. So if we were going to get a sputum sample, we could go about doing that as well, but that'll be for a different video. Make sure that you lock this back, and then part of an oral care thing that we do, or endotracheal tube artificial airway care that we're going to do with our patient, if you've got the Hollister tube holder on, we can take and move or slide the patient's endotracheal tube to the center or the other corner of their mouth. And another thing that we're going to utilize, they come in different varieties, different tools that can be done. One that's used here is the AG cuff feel. So basically what we can utilize here is to assess, it's got an electronic device in here that's going to help us determine what our cuff pressure is. So you want to make sure that you assess the cuff pressure too, making sure that it does not exceed what your hospital policies are. Document that, document the color, secretions, how well or not so well the patient tolerated the suction procedure. If they cough, it's likely to generate some secretions that may have come up above the cuff, but also nonetheless, the patient's going to constantly have oral secretions that are going to drain back to the top of the cuff. So utilize your tonsil tip suction device or Yonker and go down toward the base of the tongue and suction those secretions off the top of the cuff. And you can go down both sides of the mouth and do that. And again, this shouldn't be shoved down an artificial airway, shouldn't be shoved up a nose or anything to that effect. And if you have to use it to clean up number 2, make sure you toss it and get you a new one. And that's all I've got for that one.